Good afternoon, everyone. My name is Roxana Sultan, and I'm the Vice President of Health at the Vector Institute in Toronto. I would like to begin by acknowledging that the land on which Vector is situated is the traditional territory of many nations, the Mississaugas of the Mcraeden, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. This land is now a meeting place for many First Nations, Métis, and Inuit peoples, as well as newcomers to Canada from around the globe. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Mcraeden, and the Williams Treaty, signed with multiple Mississauga and Chippewa bands, and we are grateful for being hosted on this land. At Vector, we believe that Canadians have an unprecedented opportunity to harness world-leading artificial intelligence research and innovation to build on the data advantage stemming from our public health system. Vector supports and enables its partners in the health and academic sectors to implement leading-edge AI research to support better whole life health. Our ongoing work with various health initiatives across Ontario and Canada has highlighted a need for increased AI researcher understanding of the critical role of research ethics boards, as well as for development of education and training resources for the REB community regarding the unique nature of AI and machine learning-based research methodologies. To that end, I'm pleased to welcome you all today to this very important conversation that we are hosting in partnership with the Canadian Association of Research Ethics Boards. It is our hope that members of the REB community will build on today's discussion to develop additional training and educational resources. Vector stands ready to support these efforts with our machine learning expertise. Before we begin, we would like to get a better sense of who is in the audience today. Could you please take a moment now to respond to the online poll with the option that best describes your role? If you chose the other option, please feel free to drop your response in the chat box. While the poll results are coming in, I would like to acknowledge and thank our funders, the Province of Ontario, the Government of Canada through the Pan-Canadian AI Strategy administered by CIFAR, and our industry sponsors from across the Canadian economy. Speaking next will be Delilah Ofosu-Barko, who will provide an introduction to REBs and the important role they play in the conduct of research at an institution. Delilah is the current president of the Canadian Association of Research Ethics Boards, as well as the director of research operations at Trillium Health Partners. She is recognized as a national and international leader in research administration with over 13 years of experience enabling supports and services for health research and health improvement, including the tools, processes, and approaches to effectively manage research and improvement activities at the corporate, provincial, and national levels. Following Delilah's remarks, Rachel Zand will take over as your facilitator for the session and introduce a series of short presentations by each of our panelists, followed by a panel discussion. Rachel has over 17 years of experience as the Director of Human Research Ethics at the University of Toronto, managing its Human Participant Protections Program. She has held membership on several institutional committees and boards, including the university's Research Ethics Boards, Institutional Biosafety Committee, and Governing Council's Academic Board. She chaired the Research in Research Ethics Working Group and the Chasm REB Administrators Working Group, harmonizing processes between the university and the Toronto Academic Health Science Network hospitals. The poll results are in. Thank you for your responses. And with that, I will now turn it over to Delilah.
Thank you for the warm welcome, Roxana. As the current president of the Canadian Association of Research Ethics Boards, I'm truly excited about this partnership with the Vector Institute, particularly as it provides us with the opportunity to think and work collaboratively and bring our respective stakeholder groups together to identify and engage in opportunities for continued improvement in existing practice, process, policy, and legislation as we work to evolve the human research ethics field. I'm going to start off by providing a brief introduction to research ethics boards, followed by a primer on the Canadian Association of Research Ethics Boards, which I'll refer to as CAREB-ACCER throughout my talk, and my reflections on the opportunities that exist for advancing capabilities with respect to REB, or Research Ethics Board review, and oversight of human research studies involving artificial intelligence and machine learning-based methodologies. So Research Ethics Board, what is a Research Ethics Board? For those of you who are new to the research ethics space, a Research Ethics Board is a body of researchers, community members, and others with specific expertise that are established by an institution to review the ethical acceptability of all research involving humans, conducted within the institution's jurisdiction or under its auspices. RB membership also includes representatives with privacy expertise and those knowledgeable in applicable law. Membership specifications for REBs are codified in our federal policy statement entitled the Tri-Council Policy Statement, Ethical Conduct for Research Involving Humans, also referred to as the TCPS2, and in some instances in federal and provincial legislation. REBs are autonomous in their decision-making, and this is on the basis of the authority that they are granted by the highest authority of an institution. Grounded in the core principles of respect for persons, concern for welfare, and justice, as outlined in our federal policy, the Tri-Council Policy Statement, REB review is undertaken with the goal of assessing and making decisions on the ethical acceptability of a study. This is accomplished through deliberative dialogue among the interdisciplinary and representative membership of the REB. REB review and approval forms a component of the institutional reviews and approvals that are typically required for research involving humans. Research involving humans also extends to the collection, use, and disclosure of information about an individual for research purposes. This detail is particularly relevant to the focus of our session today. Other reviews that may occur within or on behalf of an institution for human research studies include scientific review and various administrative reviews, including privacy, risk, biomedical engineering, and information security, to name a few. In focusing specifically on the ethical acceptability of a study, REB review is distinct from the scientific and other administrative reviews that may be required for a human research study conducted within or under the auspices of an institution. For those attendees that are new to the research ethics field or with limited experience with REBs, some of the key details to know and to take away from this primer on research ethics boards regarding REBs is that they're established by the highest authority of an institution. They're autonomous in their decision-making, and they're comprised of interdisciplinary volunteer members. And one of the most important things is that the ethical acceptability review that is performed by the REB is just one component of the institutional human research review requirements and processes. The Canadian Association of Research Ethics Boards is a grassroots national organization intended to represent the interests of all Canadian research ethics boards and to reflect and provide a platform for REB perspectives, concerns, and solutions. Our mission is to serve as a national organization dedicated to supporting and promoting the work of research ethics board members and administrators across Canada. Our vision is to realize excellence in human research ethics review administration and oversight through a number of activities, including supporting and promoting knowledge exchange, professional development, and education within our community, fostering dialogue regarding local, national, and international issues relevant to our membership, enhancing awareness of REB members and administrators' contributions to the research enterprise in Canada, representing the interests of REB professionals on national and international initiatives, partnering with organizations to advocate for the recognition of adequate resources needed for REBs to fulfill their mandate, and creating and providing educational opportunities and resources needed to successfully promote ethical research. Our membership includes research ethics professionals, including chairs of REBs, REB members, REB administrators, and researchers from across the country. As a volunteer-supported organization, we rely on and are driven by the expertise and energy of our members to forward our mission and conduct our core business functions, including organizing and running annual conferences, one of which we will be doing for the first time virtually in the next month, establishing position and guidance documents, and developing and facilitating education and outreach. As you can see, our members are affiliated with various institution types, which has supported intersector and interdisciplinary dialogue and action on key research ethics topics, the focus of this session today being one of them. So, although federal policy and national and provincial legislation exist to govern REB review and oversight of human research studies, the existing policy and legislation landscape are currently silent on the ethical review of human research studies involving artificial intelligence and machine learning-based methodologies. Given the current landscape, this creates an environment where individual REBs adapt and interpret existing policy, legislation, practice, and precedents to facilitate the ethical review of such research. Varying degrees of knowledge and awareness amongst REBs, including their members and administrators, and the absence of policy frameworks and tools accessible to REBs across the country can present challenges in the research ethics review and oversight of research using AI and machine learning methodologies. Although the focus of the discussion today will specifically focus on health research, it is important to acknowledge that these challenges exist with all human research involving artificial intelligence and machine learning-based methodologies. Given the local adoption of practice, variations in local interpretation and application of policy, legislation, and precedents exist, which may introduce complications as it relates to inconsistent REB reviews and decisions, particularly with multi-site research. The ideal scenario is for a uniform standard practice for REB review and oversight of human research involving AI and machine learning-based methodologies. And this could be possible through consideration of policy modifications and the development and use of standardized tools. It's my hope that through our session today, we can enable researcher and industry understanding of the role REBs play in the health research system, and that we can equip our research ethics community with information regarding the unique nature of AI and machine learning-based research methodologies and tools to support the research ethics oversight accountabilities. Thank you for this opportunity to be a part of this dialogue. I'm looking forward to the upcoming presentations and discussion.
Thank you, Delilah, for your presentation and contribution to the session on behalf of CAREB-ACCER. We now have a panel of 3 speakers who will each be presenting, followed by a Q&A session. I'd like to introduce our first panelist, Anna Goldenberg. Anna is a senior scientist in the Genetics and Genome Biology program at SickKids Research Institute, and in 2018 was appointed the first Varma Family Chair in Biomedical Informatics and Artificial Intelligence. She is an associate professor in the Department of Computer Science at the University of Toronto, faculty member and associate research director of health at the Vector Institute, and Canadian AI chair at CIFAR, as well as being a member of CIFAR's Child and Brain Development Group. Anna's talk will discuss and resolve some of the common misconceptions about the use of AI in healthcare. Over to you, Anna.
Hi, everybody, and thank you so much for giving me now an opportunity to talk today and be a part of this exciting event. I have to say that I started working with the ethics board at SickKids over the last year, and it's been incredibly helpful on both sides. We really kind of gained understanding about how AI processes work, how we do research, and at the same time gained a more understanding about the ethics board processes, and have developed a new strategy that Melissa Mcraeden will talk about after me. But let me just tell you where it all started. I'd like to share some slides with you. All right, can everybody see my slides? Give me, maybe Rachel can chime in. Great, thank you. So there's been a lot of talk about AI in healthcare, probably I would say over the last 3 to 5 years, perhaps. A lot of talk about real integration of AI into healthcare. And there is truly a lot of potential. But let me first get us all grounded in sort of what we mean when we say AI and machine learning, and what we mean when we use this terminology. So artificial intelligence, when people talk about it, is sort of something dark and nefarious. And in reality, we as practitioners think of it in two terms. One is generalizable AI, a system that can learn on its own any concept. And there is something like this is not currently available. There is a narrow sense AI, which is something that is facilitated by the methods that people have programmed to address specific questions. And that is what we as practitioners usually mean when we say AI right now, unless we mean generalized AI, in which we'll refer to it specifically. Machine learning is a methodology, is a subfield of AI that really facilitates and makes all of these innovations possible, or a lot of them. And deep learning, which you might have heard as well, is even more, it's a specific type of methodology within the field of machine learning, which is basically, if I were to define it in two words, I would say statistics and algorithms. It's really part of computer science. But this is sort of for the general grounding of what we all mean. And ML, machine learning, and AI, I will use them interchangeably in this talk. When I say AI, I mean narrow sense AI here, and more specifically machine learning. What it's already famous for in healthcare is in medical robotics, radiology, so automated planning and radiology. This specific figure is taken from the developers and researchers here at UHN, and pathology, and there are a lot of innovations in this area, and sort of detection of skin lesions, among other questions. But there are many questions. For example, this is one of the works from my own lab, and this says goal was to predict cardiac arrest ahead of time with an opportunity to provide clinicians an opportunity to prevent it. And we're sort of able to detect an onset or predict whether it's likely to happen in a 2-hour window before the cardiac arrest happens now. And we are currently proceeding to the next stage, which is evaluation, a silent evaluation, where we are not impacting healthcare, but a silent evaluation at the hospital, at SickKids. Another place where you don't necessarily often hear, but another strategy is to figure out a policy of when to take certain tests. So when individuals are healthy, tests can be taken at regular intervals, but when a patient is deteriorating, depending on when you take the test, you will have more or less evidence. And so another student, two students in my lab have developed this machine learning technique to adapt the policy of test taken in a patient's condition. And the cost savings is estimated here, but because we take fewer tests, to be 38%. So yes, there are a lot of areas in healthcare where we feel AI could be a very helpful tool, but there are a lot of misconceptions when we talk about AI. And one of the first ones is that people refer to AI or machine learning as a sort of singular method. Something, as somebody in one of my talks said, mathemagical, when I said this is not magic, it's really math. And they said, well, we'll call it mathemagical. And I think we should not call it mathemagical because it's really math. And these are algorithms that can be understood and explained by the experts. And there are many. So there was a paper in, I think this was JAMA 2019, which sort of listed different types of approaches and how much relative human contribution is needed in decision making when they used a certain approach. And even in that stratification, so on the y-axis is sort of the method which is labeled as one requires minimal effort, whereas the methods in the bottom of the graph require a lot of the human intervention. So this human interaction as well. So this just shows you a few methodologies and how different they are on the scales. They need different amounts of data, they need different levels of human involvement and engagement. I recommend that you read this article by Bhima and Kohani because it sheds light on sort of the diversity of some of the diversity of methods used in healthcare, AI methods that can be used in healthcare. And then the question is, why does AI really need so much data? So this graph is also helpful for that. The x-axis is really showing you how much data it needs. And some of the more engaged and more expressive methodologies require a lot of data. And some of the others do not as much, but it depends on the methodology. And each methodology will be advantageous in certain settings and will perform worse in others. So there is no real one hammer or one magic wand that we can wave and say, yes, this is, here's AI and it'll work for this problem. It really, for now, requires machine learning experts to be a part of this, of the team in developing AI in healthcare. But another good thing about AI in healthcare is that many of these methods are traditionally used as standard. They exist and they can be tried very quickly on the data to see whether there is really this particular question of interest can be answered right away with high accuracy or not. And that sort of contradicts. So in 3 months, we can build preliminary models to for sort of 10 questions using different kinds of data and different integration techniques, or maybe more questions really, just preliminary models. It takes longer to bring it to the project to completion, but to try it out to see if AI could work there or not, this exploratory analysis is very, very fast and sort of comprehensive. And at the same time, we sometimes have to wait for 4 months to get RAB. So as we were discussing with our ethics board, it doesn't really make sense to sort of, you know, more than double this this exploratory project, because this exploration stage, it doesn't really result in a publication yet. It just says we can try a methodology, we can see whether we can get high accuracy models that would proceed to become either publications or deployed at the hospital for quality improvement. So this is an important point. Another very common misconception is that not only AI is a black box, but that AI experts really don't care, that we're all comfortable with these black boxes that we are tossing around. And this is sort of the state and reality. And this is certainly not true. In fact, it's not very different from what is happening in the hospital already. So if you think of input, we'll call it X. It can be called anything. It's input. And we have this outcome that we care about, which is Y, which can be, you know, a need to do surgery, a need to perform a test, whether the cardiac arrest is likely to happen, etc. Any of these outcomes. All we are trying to do is to figure out what is this mathematical function that will take us from the input, from the characteristics of the patient to predict this outcome. And this is exactly what clinical practice is, really. There are rules. The specific, in many cases, the specific function is a set of rules that clinicians apply to say this is an outcome. Well, in machine learning, we know that rule-based, a lot of the times, rule-based systems are inferior to some of the other mathematical functions that we have. It's just one type of an opportunity. Another sort of way is the gestalt, that the clinician has a sense that this patient might have this problem and needs to be tested for that, right? And this is even impossible to standardize. It's very hard. And so this is where we hope that AI will really come and help to sort of standardize the care and make it better across. Another common misconception that I hear a lot is that the AI is here to replace clinicians. And this is really not happening anytime soon. Fifi Lee, who talked at the AI and Healthcare Symposium in 2019, she said the verb we use in healthcare AI is augment, not automate. So the way that I often think about it is that it may be just another test, just a more sophisticated test that the clinician can do to obtain the evidence that synthesizes all the information that they have, which is very multidimensional, sort of hard to parse for a human mind and maybe easier for the machine. And they have this one other piece of evidence to consider in their decision making. This one is one of the most common misconceptions, listed as 4. The numbers don't matter. The fact that we all want to have models that we understand. And the reality could not be further from that misconception. So there was I'm citing a paper here that did a study on this, but there are many studies that are coming out right now. And so it is true that people can better simulate a model prediction when model has very few features and they sort of understand how it works, especially when it's just a linear combination of features. But to what extent do people follow a model's predictions when it's beneficial to do so does not depend on how clear the model is and whether they understand it or not. So this study showed that this was not the case. And furthermore, that models that are perceived to be transparent, that humans think that they understand better, they tend to follow them more without as much critical sort of thinking at the decision processing level than models that they believe they don't understand and maybe more suspicious of. So transparency may actually lead to more serious mistakes at decision-making time. And this is research that's coming out because there are many cases where simple models are just not adequate for the complexity of the phenomenon that we are trying to model and understand. And this is a really critical point to sort of start taking home, that simple models may be harmful at the bedside. A, because they're not as accurate, but B, because they may mislead people because they make more mistakes, but people trust them more. So this is part of the sort of AI in healthcare and education and critical thinking that we are hoping to embark on in the future to make sure that there is a really good sort of understanding by the users of what these models can do. There's a misconception, maybe it's more in the computer science space than in the healthcare space, but that AI in healthcare can be done by just AI practitioners. And the reality could not be further from the truth again. AI in healthcare definitely is a team sport. This was highlighted in our paper in Nature Medicine, but it was also highlighted in a report by the Royal College of Clinicians and Surgeons. This is the need for the teams is for clinical champions, IT, software developers, designers and human-computer interactions, hospital decision makers. Without everybody being on board, it just doesn't happen. And this is really, really important. And the question is, why do we need so much data? And I want to give you an example. I was promising not to talk as much, but I feel like this can be helpful to understanding why is it that we need all this data, and especially the sort of PHI data. Why would we need that? So here's an example. We worked in collaboration with a clinician to predict whether the lump in a neck is likely to be cancerous for thyroid cancer. So usually what is done in a clinic is ultrasound is done if there's suspicion of malignancy, then a biopsy is done. If suspicion of malignancy, then a surgery is done. And it turned out that there are 67% of the surgeries result in benign nodules, which means that they didn't really have to be done. So could be the patient could just be monitored. So we developed an algorithm that could reduce that number. But in our validation set, we predicted this, that only 2 out of 7 on whom the surgery was done needed surgery. But in the 3 malignant patients that we had, we predicted only 2 out of 3. And the algorithm was quite sure about this. And we went back to our expert and we asked, why is this the case? And he said, oh, but this is I remember this case as a very particular case. It turned out there had to be some family history that made me think that that we should do the surgery in this particular case. That information, the family history, was not part of an algorithm, was not available to us. So maybe initially it wasn't thought as one of the important features to include. That's why the context is important. That's why we ask for all the variables, because it is very often that as humans, we don't think of what variables may be important ahead of time. And all the available data that is collected, that's what we ask for usually. And that's then we can use an algorithm to determine which of this variables are really important, and it doesn't take us long at all. And we won't use PHI data if it's not important. So another good example of that is the classifier for no-show appointments, right? Seems like it's perfectly fine, but this is within EPIC, in the EPIC Orchard, this was available as an algorithm before. I don't know if it's still available, but that means that a lot of people had access to try to use and implement it. So basically what they did is they used 7, I think on the order of 7 variables, and the variables that weighed most were race and socioeconomic status. So they went in the implementation of the system, they basically overbooked appointments for African American and poor people, which already require more attention in the system. So the bias was exacerbated because the bias was in the system, in the data. And there are, again, many publications right now that say, coming out of the machine learning field, to say we have to be very, very careful with bias and we have to address it. But guess what? In Canada, we haven't been collecting race and ethnicity information to make sure that this does not happen. So we can't even test for this. This is the importance of collecting and incorporating such data into our algorithms. So in summary, there are many successes. There is a lot of really great potential of AI to help. These projects for many of my colleagues are done in great collaborations in teams with clinical champions driving this project. And I think there's a lot of excitement, but there's still much remains to be done. And in the ethics space, and I think that our global sort of understanding of what AI is and how to review it and streamline these projects will go a long way to making this innovation possible for our patients to benefit from. Thank you.
So I'd like to thank you, Anna, for your presentation. You touched on several points that we will definitely be expanding on in the Q&A session. I see people are putting their Q&A questions in, and we will get to them during that session. I'm now going to introduce our second panelist, Melissa Mcraeden, who will provide further information on how machine learning health research is designed while maintaining a research ethics perspective. Melissa is a bioethicist at the Hospital for Sick Children and a project investigator with the Genetics and Genome Biology at the Peter Gilgan Center for Learning and Excellence. She co-teaches empirical bioethics as an assistant professor at the Delilah School of Public Health at the University of Toronto. She participates in the Consort and Spirit AI Working Group, which created the reporting guidelines for AI clinical trials, and she is involved with a number of other reporting guideline initiatives for health AI. Her research focuses on pediatric bioethics and the Ethics of Healthcare Machine Learning and Precision Medicine. Over to you, Melissa.
Thank you so much. It's really great to be presenting here today on this work, which was really a team effort at SickKids, but particularly I wanted to acknowledge the work of Elizabeth Stevenson, who is our REB chair at SickKids, and James Anderson, who supervised the initial parts of this project and who has expertise in research ethics. So I'm really grateful to both of them and to Anna and her team and our many collaborators who helped us work through this process. So this really started because there was a genuine question within the machine learning community as to what constitutes evidence of machine learning in a way that can be likened to the evidence that we try to gain from clinical research to try and understand what new technologies might be in our patients' best interests. And so trying to fit in where AI might be operationalized through this system is a really complex question because there's a number of different stages. And so we really initiated this pathway to set up the different stages that could generate different kinds of evidence and that could fit into an REB oversight process. So I'll go into each of these in more detail, but essentially this is divided into 3 stages. So the first step is this stage of exploratory machine learning research. So this is where the machine learning researchers are asking questions like what relationships are apparent in these data, what tasks can machine learning perform, and what knowledge discovery may be conducted through exploration of the data. Once the team has developed a model meaning a mathematical relationship representing a specific medical phenomenon, we then want to test that in what Anna introduced as a silent period. And so this is where the team is really testing the ecological validity of the model. So is this capturing what we're hoping it's capturing in the real world? Would it be feasible to implement? And where would the ideal placement be within the clinical workflow? In the third stage, we're looking at prospective clinical evaluation. So this is where we're really asking the question, is the use of this model beneficial to patients and clinicians and under what conditions? And so going a little bit deeper into each of those stages, the first one that we have is this exploratory stage. And Rose Gaitero, who's our REB vice chair, has been really instrumental in helping a lot of teams get together what we've called data access protocols, which describe a method of data governance. So through these protocols, we enable teams to explore multiple research questions under a single governance structure. And as Anna stated in her presentation, there's good reasons for this, and I'm going to dig into that into the next slide. But the way that we have seen this is through TCPS2, their provisions for secondary use of data. And so this refers to the retrospective retrieval of data that was originally collected for a different purpose, in this case for clinical reasons. Now, the TCPS2 allows for a waiver of consent to be offered by the REB if it is the case that it is that the project is of minimal risk and if it's infeasible to contact all individuals to request for consent. And I'm going to talk about that a little bit later as well. And so we've sort of captured this within the REB system as a prospective, retrospective observational study. So prospectively collecting data from completed encounters. So this is from our paper, and it describes the procedural modifications that were put in place to facilitate these kinds of protocols going through the REB. And so the first was that we allowed a group-based approval. So rather than having a specific project as the trigger for the application, the protocols refer to a specific group of individuals who have sufficient training and qualifications. And again, specifically, as Anna articulated in the example with detecting thyroid tumors, we moved toward a model of PHI protection rather than strict minimization because of those particular challenges. Now, even within there are specific kinds of PHI that will not be needed for machine learning. And there are many different projects or tasks that are not necessarily, that don't necessarily require the same level of PHI. And so within the protocols, you can specify whether that will be available. And the PI is accountable for keeping track of which individuals who are approved under that protocol have access to which level of identifiable data. Now, we have allowed for the scope of the project to be a broad goal without a predetermined methodology. And this is particularly important because machine learning researchers don't want to come into looking at the data with particular biases about what can and can't be modeled, because it can push you toward trying to accomplish a particular thing, which may not necessarily be clinically reasonable, or it might bias the research endeavor itself. So whereas a typical protocol, you might pre-specify your statistical analysis plan, in this case, we've allowed researchers to state that they will be applying machine learning techniques, and this enables them to compare different methods that can then be used to make a justified decision about which model would move forward to potential clinical uptake. And so to enable accountability, we've used these frameworks to really articulate the governance of data, how it's collected, when it's collected, how is it de-identified, by what processes, where is it stored, all of those typical things that anyone uses with an REB application that involves PHI. And then also allowed for pre-specified and frequent data retrieval without repeated amendments. So again, a little bit different from a typical retrospective, but one that enables the researchers to keep the model up to date concerning local patient trends. Sometimes policy decisions make a difference. And so really making sure that that model reflects the best available data. Now, the AI chasm is a term that was coined by Pierce Keen and Eric Topol, which described that in a historical data performance, we can get really great accuracy. The model looks really good. There's cleaning of the data, and we can get really good performance of models. However, in a live clinical environment, the data is a lot messier. We're dealing with a live data stream. It hasn't been pre-cleaned. And also the collection, when you're looking at the historical, all the data has been collected, the encounter is complete. But when you're trying to model these same issues in real time, you're dealing with incomplete data. And so a lot of models actually fail at the point when they are trialed in the clinic. And so Anna Goldenberg's work, actually in the same Nature Medicine paper she referenced earlier, really pointed to the need for a silent period evaluation. So this is where the model is run in silent mode. Essentially, it is making predictions in real time as it would in clinical practice, but those predictions themselves are withheld from the treating team. So they're not being used to make any decisions about a patient's care. They're being recorded. And what the research team is doing is checking whether those predictions are aligning with the real world outcomes that are happening to the patient. And so we've argued in our paper that this is necessary for clinical equipoise. So traditionally, the justification for proceeding to a randomized controlled trial, we've argued that performance in a historical data set is not necessarily enough to trial a model in a patient population where it might be used to make decisions, that we really need this additional step before we actually proceed with trialing a model in a clinical environment. So procedurally, for the REB applications, this is dealt with as a prospective non-interventional trial. The goal of the trial is to test this hypothesis that the model is feasible and can have clinical applicability. There's also model validation that goes on at this step. So calibration and assessing technical performance, looking at where it sits within the workflow, and also considering staff views and values and feedback on the model. And so this is all toward the idea of clinical evaluation. So we don't really know that the model is going to work unless we're checking whether those labels or whether those predictions within the model are lining up with these real world events. So once we have that, once we've run a model through silent trial and it's demonstrated acceptable performance levels, then we want to test the hypothesis that the model as an intervention results in a net benefit to patients. And so as Jenna Waynes has pointed out, we're looking at a generalizable approach, not necessarily generalizable models. As you can imagine that as a mathematical equation that has to take into account everything locally about what's going on with the patient, that mathematical equation may not look exactly the same at SickKids as maybe it does at GEO. But the approach itself may be generalizable. So in applying this machine learning methodology through this process, evaluated on this outcome in this manner in the clinical workflow, that approach itself might be something that other sites could then do locally as well. And so at this stage, we're really looking at clinically relevant evaluations. So previously, we've been focusing on the model's performance characteristics. And here we're focusing on what is the effect on patient outcomes. And there's many ways to do this, as we know generally within clinical research, all from an observational trial to a full randomized controlled trial, and they have different strengths of evidence and risk of bias. So the goal of the trial, as I've said here, is to test the hypothesis that using the model might be superior to standard of care. We're looking at generalizability of the approach through the research process. And again, to look back to Anna's presentation of the no-show prediction tool, we think it's really important to look at disaggregated performance metrics at this stage. So not just looking at on whom is the model predicting best, but also on whom is the model predicting well in a live environment as well. And we think that these things can be really important for thinking about clinical uptake, for patient safety, and for justice. And so these last few points are captured in the New Spirit and Consort AI guidelines, where they emphasize that the model really needs to be evaluated at its intended place within the clinical decision-making pathway. The model outputs need to be recorded and the clinical decisions taken need to be recorded. And we need to understand what potential discrepancies might be between a model output and the clinical decisions that were made. Now, from the REB perspective, some of the things that have been found helpful have been to use these reporting guidelines as checklists to actually generate templates for the REB applications. And it's also really important to get machine learning researchers involved in the REB. So they've been helpful in terms of conducting some science review. This is a particular kind of expertise that many on REBs don't have at this point. So it's really helpful to have that lens. They're attuned to particular risks that many of us might not be aware of. And they can also comment on the validity of the research endeavor. So as the field progresses, particular methods may not be as appropriate anymore. And so machine learning researchers can provide some really helpful guidance on that. So some of our next challenges, because this pathway is by no means at an end point. So we're looking to scalability. So our REB has gotten very, very busy. So we're now trying to think of how can we scale up the ethics review process. So one of the ways in which that's been apparent is that sometimes in single units, we might have multiple models that are being tested under fairly identical parameters. And so considering how we can minimize some of the burden on REBs, but also ensuring that teams are aligning with best scientific standards is important. We also want to think a little bit about cross-institutional data sharing. So sometimes this is really important for checking the external validity of a model. So if a model can generalize to a new site, it requires testing it on external data. And then one of the key pieces I think here is that the approval of research and approval of a waiver of consent by the REB, I would say, and this is represented in this paper, is entirely separate from an ethical obligation to promote trustworthiness and transparency in research. And that means thinking about how can we get consent from patients moving forward? How can we involve them in the research process? Because really the TCPS2 guidelines didn't necessarily foresee the way in which we might be using retrospective reviews today. And so really thinking about what are the long-term, what are the ways that we can facilitate trust and sustainability in research more generally, but in AI research particularly within institutions going forward. And so just to conclude with thanking all of these people, we've learned so much from the teams who have been bringing forward their models and their research plans. And so I'm really grateful to all of these individuals for their collaboration.
Thank you, Melissa. Your presentation is continuing to give us more and more food for thought. We have one last speaker, and then we will go to the Q&A. The next speaker is Jay Shaw. Jay is a scientist at the Women's College Hospital Institute for Health System Solutions and Virtual Care and research director of Artificial Intelligence, Ethics and Health at the University of Toronto's Joint Center for Bioethics. He has a status appointment as assistant professor in the Institute of Health Policy Management and Evaluation in the Delilah School of Public Health at U of T. Jay sits on the Ethics Review Board at Public Health Ontario and has an active program of research in the ethics of AI for healthcare. So over to you, Jay.
Thanks so much, Rachel. It's been great to listen to the few presentations that have been given so far. And I think there's been lots of new ideas probably for Research Ethics Board members, lots of new ideas for AI machine learning researchers. So I'm just going to spend 5 minutes providing a bit of reflection from the perspective of public health, which I think is has the basic structure of ethics review of AI machine learning studies closely maps onto what Melissa has just presented, but of course presents some unique issues. So I'm just going to talk for a few minutes to outline what some of those unique issues are. Now, for some context, I am on the Ethics Review Board at Public Health Ontario, and we have been working since last summer to develop an ethics review process for studies that use AI machine learning methods. Now, I certainly don't speak for Public Health Ontario or for their Ethics Review Board, but I've been working closely with Nancy Andrusek, who's the Director of Research and Ethics there, and Elizabeth Peter, who's the chair of their Ethics Review Board and their team. One of the first and important overarching takeaways, I think, from what Melissa has said is that there is an emerging process for the review of machine learning studies in health. And I think this is when we first got started, we did a review of the literature and spoke with stakeholders fairly widely and really heard about just the complete absence of any clear framework for doing research ethics review of these types of studies. And from looking at what's available in the literature and what we've heard from Melissa and Anna and their experience, we can see that starting to emerge. Now, in a hospital environment, the 3 phases make really good sense that Melissa has presented, basically funneling toward an actual experimental evaluation of an AI intervention in a sense. Now, of course, public health is a bit different because of the kinds of interventions that are developed for use in public health and the kinds of machine learning studies that are done on this level. Now, one important point, and I'll echo something that Melissa said, is that this process is emerging, but it's incumbent upon every individual research ethics board to understand the particular AI technology being developed, the particular model being developed. What is it intended to accomplish, or will it accomplish? And I think this is the real challenge that's faced by research ethics boards, because while we can present these this overarching concept, this overarching framework for thinking about ethics review, first with model building focused on data governance, second with a silent phase, and then third with a proper prospective evaluation, it still fundamentally depends on the particular use case for the AI or machine learning technology. And that's up to the research ethics board, independently to come to a decision on the ethical conduct of that particular research on that particular technology. So I will echo Melissa's point in saying, for all of the AI machine learning researchers out there, reach out to your REBs, offer your expertise, because I can tell you that's a crucial part of this discussion. So I'm going to move on to quickly summarize 3 lessons that I've learned so far on my work on this topic from a public health perspective. The first one, is that there are fairly clearly these conflicting logics, different logics at play. You have the research ethics board logic, which is about the protection of human subjects. And you have the machine learning science logic, which is about advancing machine learning methods and advancing science. So these come to tension at particular points in the review process. The most obvious one I've encountered is the conflict between the natural inclination of research ethics boards to support data minimization, using only the exact amount of data that's necessary to answer a question, and the effort to train robust models, as we've heard from Anna and Melissa, in the machine learning mindset. So there are these different tensions, and the challenge of the Research Ethics Board is to produce a process for reviewing these studies that enables the science. So it needs to address those, in a sense, conflicting logics. And these insights also have grown from a conversation I had with Melissa last summer. So on to the second point, one of the things that became apparent very quickly from the public health perspective is that attention shifts away from individual level harms toward group level harms. And what I mean when I say this is in a typical clinical intervention study in a hospital, the attention is paid primarily to any harms that might accrue to individual patient as participants. Now, when we're looking from a public health perspective and these large machine learning models that could inform public health decision-making, the attention shifts toward the harms that might accrue toward groups. And if we think about even a small discriminatory harm that might accrue to individuals as a result of an applied model at the level of public health, so large-scale populations, those small discriminatory harms add up very quickly to a very important group level harm. And that leads into this discussion about community engagement from a public health perspective. Have researchers gone out and actually talked to the community members who would be affected by the general topic of the model that's being built? And this point around when is it appropriate for research ethics boards to suggest that researchers do community engagement? How would machine learning researchers do community engagement and do it well? This, I think, is a really important point to be worked out, I think, for the entire research community, but especially for machine learning researchers looking to gain access to these large data sets. And that's closely linked to the important attention being paid to the possibility for group level harms, harms that accrue to particular communities or particular groups. So that's the second point, group level harms, and linked to that is whether and how people should be doing community engagement, checking whether the topic is of interest and any potential harms that may accrue to that community as a result of research on that particular topic. And then third and finally is around the meaning and significance of different data sources. So I know a number of research ethics initiatives in the machine learning domain more generally are in fact focused on the challenges, the ethical challenges of bringing together different kinds of data sets. Social media data that is, ostensibly publicly available and continually generated, when linked with other kinds of data sets, can have quite profound implications. So I know there's work on this topic ongoing in Canada, and at University of California, San Diego, there's a group called the Connected and Open Research Ethics Platform, or CORE. And they offer a series of research ethics focused review resources for assessing studies, especially that use ubiquitously collected data like social media data. So the meaning and significance of those data sources, the implications of them being linked, and what that means for the potential harms posed by a given study. So I'm sure we'll have lots of opportunity to dig into some discussion. So I'll pause here and put it back over to Rachel.
Okay, thank you, Jay. In the interest of time, we are going to go straight to the Q&A. And there are already some questions that have been posted. I actually will start with one looking at what is currently on topic for machine learning in terms of COVID-19 research. So I recognize that there are researchers wanting to look at, for example, the Ontario Health Data Platform and others. So maybe I'll start with Anna. How has machine learning been used so far for COVID-19 research, and how have results been put into practice?
This is an excellent question to which I will try to give a proper answer. So several things have happened. there are great innovations, and much work has been done in the sort of genetics, genomics area, where biological and cellular information is available to scientists. Some work has been done in the X-ray, sort of predicting whether it's pneumonia or COVID from the imaging. There is a lot of work in that area. There has been, though, a recent paper that came out saying that a lot of the publications were not done rigorously enough. And so some of them have, I don't know if they're being retracted, but yeah. We ourselves are working in the wearable space, trying to predict whether it's likely to predict COVID from Fitbit type watches. And there are a lot of publications in this area as well. And ours is going to be similar to the one that says that a lot of the work has not quite been done properly, and the signal is not very strong, as strong as the previous publications indicate. So that paper is in preparation. However, there is a sort of a sad part to it, is that public health hasn't benefited as much from these. These are all sort of this in the research space. There's a lot more done in research space than the patients and public health systems see. And one of the reasons is access to data. So access to data has been very difficult. We've been working with the ministry for a long time, trying to establish platforms to make it easier, and it's taking time. And it's taking time because there are rules and regulations right now that require a lot of this sort of systems to be worked out. That takes time. So somebody on a recent sort of panel, somebody mentioned that AI has been absent from COVID, or it looks like. It's not true. There's definitely these areas that I've mentioned where research is going quite well, and there are quite a lot of publications in that area. Also, predicting which drug is likely to be responsive in that area, AI has been used, and successfully, to a certain extent. But with public health and with ministry data and our attempts to help sort of Ontarians with to understand more about COVID in Ontario, we are still a bit behind, and in terms of data access.
Great. Jay or Melissa, do you want to add anything? No? Okay, I will go to a second question, and this is for Melissa. How do researchers strategize, I know you talked about this a bit, on avoiding bias within their data and algorithms? We know that there are many factors that determine whether individuals or populations will be in activities that generate health-related data. How do researchers prevent skewing of results because some communities or populations are over or underrepresented?
Yeah, that's a really big issue at multiple stages in how we evaluate algorithms, and it has huge practice implications. So what we've sort of done at the R&D level is for the exploratory work, we've prompted applicants to provide a statement of social impact, which aligns with some of the best practices from NeurIPS and Machine Learning for Health, the big AI conferences. So that at least gets them thinking a little bit about the ethical implications of their work. And then at the silent trial and the prospective stages, we've really advocated for disaggregated performance characteristics. And I think it's quite complex because it involves, first of all, like a values-based notion of what is bias versus what is difference, because we can imagine that within a given disease population, there might be some patients who are underrepresented just because their particular clinical phenotype may be less common. And then there might be other reasons that pertain to lack of access, facing prejudice, distrust of healthcare systems. And so really understanding what that bias means, what that empirical demonstration of bias, what it means ethically, is something that I think involves not just the researchers thinking, but collaborating with other individuals who have experience perhaps in the intersections of race and medicine, in social determinants of health. So really the reporting of results and the looking at the different performance characteristics is a discussion point for enriching the research endeavor by having colleagues weigh in as well.
Jay, you want to add?
Yes, please. Thanks. Thanks, Rachel. I think, just to echo a point that Melissa raised is around that point in particular, raising the crucial importance of interdisciplinary collaboration. And, if you're a machine learning researcher and you don't know a social scientist, go find one, or keep an eye out. Because, I was recently reviewing a 2019 paper, survey on bias and fairness in machine learning, Mcraeden et al. And they outlined 23 kinds, ways of understanding bias. Perhaps that's a paper that's familiar to some of you. Even at that, there are ways of understanding what constitutes bias and fairness in ethics and the social sciences. And this is crucial, that will be understood by members of the REB. And if you're submitting a social impact statement, then it needs to be something that members of the Research Ethics Board will understand and relate to. Thanks.
And I just wanted to add to that, Jay, you had a question regarding your suggestion that researchers do community consultations. And the question is, how realistic is that? And is there a concern that the results would be simply anecdotal and that you may not even get the target populations that you're looking for?
It's a crucial question. And I think community engagement is something that is ideal in concept and challenging in practice. There's no question about that. I guess I would say that the organizations, research ethics boards that approach their work from a strong social justice perspective will express concern for the disproportional impact or harm of the outputs of these technological interventions on so-called vulnerable communities, those communities who tend to be structurally marginalized. And that means their access to opportunity, and we're speaking specifically about healthcare. So their access to healthcare and outcomes of healthcare are poorer as a result of social and policy and historical circumstances. So building relationships and doing work that's meaningful for those communities takes time. And there's, in the community-based research world, there's a clear acknowledgement that that kind of work is not incentivized in the academy. So, with all of those things in mind, I think it's very rare that a research ethics board would say, what you've proposed requires engagement with a particular community. However, on the back end, some of that work is already being done. ICES has a First Nations Inuit Métis Advisory Council that provides guidance on the appropriateness of access to Indigenous data, Indigenous health data in particular. So there is infrastructure for doing that kind of work. And I do think that to really truly consider the impact of any kind of innovation. I'm not specifically talking about AI technologies, but any kind of innovation on structurally marginalized communities requires input from those communities. The fact that we are here, we're being paid right now, many of us, means that we don't have access to the lived experiences of the people who may be affected adversely by many of these innovations. So, I'm sorry, it's a long-winded answer to say that there is some infrastructure for focusing on this. It's really important in concept. Operationalizing that is a real challenge, but I think is something that this community, broadly speaking, should be working toward.
Rachel, can I comment as well?
Absolutely, go ahead.
Just to follow Jay's comments, I think it is absolutely crucial to talk about communities that have been marginalized, not as sort of people who are lacking access and we should help them with that, but as a partner in developing technologies that they want, because there is an opportunity to leapfrog over a lot of these things that the healthcare inefficiencies that we already have in the system. But it has to be coming from the communities. And I think that there's a sort of understanding in our society that is backwards, in a sense that we want to do better for them, but they've been all along asking, you listen to us, what we need. We do we'll work with you. Just work with us. Don't do something for us. Let's do these things together. And I think your comment about partnership is right on. And communities that have been marginalized, there are different kinds with different needs, but really establishing these partnerships and figuring out what these communities need, and them bringing it to this partnership, their needs and sort of abilities of AI, what AI can do, because in our interactions with Aboriginal communities, they're incredibly interested in what AI is. They don't necessarily have access to this information, and then they can decide what of that they want for their healthcare and what they don't. And so I feel that I approached this subject also as in they should just know and then they'll want it, but the values and the culture have to be considered, and we really truly have to be establishing partnerships, something that we are really eager to do now.
Thank you. Okay, another question. This one, I think Melissa, I'll send it to you, and everyone else can expand after. How would standard machine learning derived methods affect personalized medicine? So I know you're working a bit on that.
Yeah, so I think potentially can depend on how we're thinking about personalized. So sometimes, clinicians will often respond, we personalize all medicine and all care delivery. And so with the context of ML, I think one aspect of that personalization is perhaps with risk assessment that is particular to the individual features of that person. The ability of machine learning to do that is something that often exceeds one individual's ability, particularly those who haven't had as much experience sometimes. And so I think of it sometimes less as the idea of personalizing everything, but in setting a personalization standard that enables consistency and minimizes errors sometimes. That being said, there's a different connotation as well of machine learning use in personalized medicine, which Anna has done a lot of work in. So in subtyping, looking at particular phenotypes, so exploring data and generating clusters of phenotypes or groups of individuals who might not have otherwise been observed, because we might have such a small kind of sample that an individual clinician or unit might see. And so through application of machine learning methods to larger databases, we might be able to identify particular clinical phenotypes or genetic groupings. So I think those are a couple of ways that we could apply machine learning to personalized medicine.
And do you also want to add something? Okay, I'll go on. This is around data. There's a question about, and it's for Jay. What kind of research has been done on data anonymization in combined data sets? Are there protocols being developed to ensure that anonymized data from multiple sets remain anonymous when combined? Similarly, are there any restrictions on combining certain data sets to protect the anonymity of patients?
This is a great question, and I think has been an important focus of attention in the machine learning community for quite a while, over a decade now. I would say I'm not aware of sort of AI methods that for the preservation of privacy. I'm sure they do exist. Perhaps Anna or Melissa would like to comment on that. What I will say is that the sort of data governance community acknowledges tiers of de-identification. So we can have sort of maximally de-identified data, or not, or fully identifiable data, and that there are established processes for de-identifying data according to those kind of tiers. Anonymized data is different, and my understanding is that anonymized data usually refers to data that's already been analyzed or aggregated in a sense. And so that data, it's impossible to go back, in a sense, unscramble the egg to get to the more specific data sources for what the anonymized data is. Now, I mean, there have been some really high profile cases where groups of people have released data sets to say, this is a very well de-identified data set, and we challenge people to see if they can re-identify. And every case I'm aware of, the data has been re-identified. So this is, I think, a crucial issue from the perspective of research ethics. And I think it guides many of the decisions made around research ethics governance of access to health-related data. So this is where we see the data governance approach and access for groups, as Melissa outlined. This is a trusted researcher model, and that's, from a research ethics perspective, this is a model where only those people who have a track record, made agreements, demonstrated that they have the expertise to abide by a particular privacy-respecting, privacy-preserving data governance approach are even allowed access in the first place. So it's a non-technical solution, but something that's in fairly widespread use across the globe. So not a technical solution, but a research ethics one nonetheless, focused on a trusted researcher type model. So I'm not sure if Anna or Melissa want to add to that.
I'm happy to chip in. So several things. First of all, of course, there is a privacy-preserving research in the field of AI. There is differential privacy in healthcare, where at least one of my students has also contributed research to. And for now, there is no sort of scrambling of the data that preserves the accuracy or performance, right? So we have to decide, are we protecting patients' privacy, or are we protecting patients from better care? And what is more important here? And I think this is one of the sort of things and issues that we are struggling with. Once the data is completely anonymized, if that's a requirement, for example, for a project, there is no way to bring it back to the patient to help this specific patients whose data has been analyzed. So this is not a way, because I think a lot of our work in hospitals is really, it's ultimately it goes to improve, to quality improvement, right? It's research which has quality improvement implications. And so there there are several things here. I think de-identification also has a limit. What is the purpose of de-identifying the data before the researcher sees it? So for example, none of the machine learning researchers really need to see the name of the individual. But the zip code, for example, could be very helpful as a proxy for, for COVID, right? Some of the zip codes have much more prevalence of COVID than others, and this is a proxy for those, or SES, or things that definitely weigh into the susceptibility to diseases. One of the sort of cases that we had is that we were told originally that we will get the COVID data, but everything but a year will be scrambled. This was in 2020. What is the purpose of telling us that everybody is a 2020 COVID patient. There's no, but the data itself is very useful. And we were told that actually we could get extra information if we file additional documents with an additional review. You know, COVID is here. COVID is here. And none of the researchers have asked for the exact date because nobody could fathom that this data would not be available. It's one of the critical points of COVID, right? When exactly it happened and where on this, you know, this third wave we are now, where exactly in this wavy spectrum this illness happened. I think it's really important to be thoughtful about what we are trying, what the ethics is trying to protect, right? Because ultimately, RIB is trying to enable researchers to do the work, right? And if we make it into a staged process, a very lengthy process, that ultimately we might get the data, but it may be too late for this time-critical project. We have to ask ourselves, did we do our job, right? It may be unethical, the fact that we don't have the data yet. That may be unethical, right? So there are lots of these issues that I think need to be discovered and discussed and acted upon and more streamlined. But one last comment is about research, sort of trusted researcher comment. And people who benefit the most from having fast access to data are new investigators, right? And they might not have any history of that. They might not have any established history of doing that. Some people come into the field of healthcare, amazing researchers from other fields where they didn't work with human data, but they're no less extraordinary and have no less to bring to our field. And so while you know, I would certainly, from my perspective, be very happy if trusted researcher sort of passport or something like that label existed, because I've been in this field for a long time. I know that in the beginning, the only data that I could get access to in reasonable time was publicly available health data. So I think we have to ask ourselves, are we in healthcare field wanting to benefit, wanting Canadians to benefit from that, from AI, and how soon? And this is a critical point, and I think this is what the government is thinking about now, and that's why all the regulations are sort of changing right now, because I think the answer is yes. I think we are. We want Canadians to benefit soon, and no Canadian data is public right now.
I think to your point, it goes beyond the remit of REBs, because we can allow people access to data, we can provide waivers of consent, but ultimately, you know, the key to a sustainable and trustworthy movement towards systematic use of AI in healthcare is really gaining that meaningful involvement of patients and families in what we're doing, letting them know what we're doing, providing them options, because we see that, you know, in genetics research, in my own history of doing work with patients with brain tumors, they don't mind, they don't have a problem when identifiable or potentially identifiable data like visit date or age might be used, so long as they're assured of that it's going to be kept safe, that it's going to be kept protected, that they're going to know what's going on, that they've been asked. So I think, you know, really moving toward that, and particularly looking to, you know, the social groups who have distrust of health institutions, and really understanding what it's going to take to foster a more meaningful relationship with them particularly, I think really is the key, and it goes well beyond the REB remit.
Thank you all. Unfortunately, we're coming very close to the end of the session. There are several topics we've just started on, a lot of others that we really still need to get to in terms of a larger conversation regarding machine learning research. But what I will do right now is I will put up a poll. And this is looking at what kind of future educational opportunities you want in terms of area. So please fill out this poll and we'll see the results soon. In the meantime, I'd like to thank Anna, Melissa, and Jay for their presentations and participation. I'd also like to thank all of you audience members who put Q&A questions into the Q&A section. We will go back and try to answer everything that we can. I know there's several that were not answered. I'm sure everyone has gained important information on how AI and machine learning is being used in generating new knowledge in health to the benefit of society and the ethical tensions and considerations that these technologies pose. I'm now going to turn things over to Roxana for final remarks. So thank you all.
Thank you, Rachel. I'd like to echo appreciation for the speakers and the audience, and also to thank Rachel for all of her efforts in shaping this conversation today. I'd also like to acknowledge the incredibly helpful role of the Canadian Association of Research Ethics Boards in co-hosting today's event with Vector. We look forward to seeing the work that the REB community drives as a result of it. And finally, I'd like to express thanks and appreciation to Chiara Lacey and Hope Nestor for all of their work organizing this engaging event, which proved to be much more popular than we had expected it to be. As mentioned before, a recording of this talk will be made available on the Vector Institute's YouTube channel. Thank you once again, everybody, and stay safe.